Please take your seats. The session is about to begin.
And do we want to do a clearing the room one?
When extreme weather strikes communities already struggling with significant challenges, such as conflict, economic instability, and limited resources, fragile health systems can quickly become overwhelmed. Treatable conditions become life-threatening, and people who are already suffering are forced to bear the unimaginable. Based on our decades of experience in these environments, International Medical Corps knew that these complex situations required not just a new solution, but rather a new approach, one with climate resilience as a foundational consideration. So in 2023, we launched a fund dedicated to helping low-resource communities strengthen their health systems to withstand extreme heat waves, droughts, floods, and other unforeseen challenges as they arise in today's rapidly changing world. Since then, we've been working with national and local partners to implement solutions developed by and for communities on the front lines of weather-related disasters. These projects strengthen infrastructure and increase the capacity of health systems and community members to withstand and adapt to our changing world. From the Central African Republic to Pakistan to the United States, International Medical Corps partners with communities, governments, health organizations, and donors to invest in sustainable, community-based health initiatives. Through preparedness planning, health infrastructure improvements, training, and public education, we're reducing suffering, building resilience, and increasing self-reliance. When health systems are strong, communities are more resilient, and people have the opportunity to lead happy, fulfilling, and productive lives. That's the world we imagine, and that's the world we work every day to create.
Please welcome to the stage from Last Mile Health, James Nardella.
Good afternoon. I'm James Nardella. I serve as President and Chief Program Officer at Last Mile Health. Being back at CGI reinforces the idea that there's value in maintaining a long obedience in the same direction, that progress and a meaningful life come from sustained effort, not from quick fixes. You see, I first came to CGI in 2009 as a wide-eyed executive director of a fledgling but fast-growing community health organization in Western Kenya, a region with disproportionately high maternal and infant mortality rates. Our ask to the CGI community was simple: help us launch a maternal and newborn care program through a commitment to action we called Safe Mamas, Safe Babies. Thanks to our CGI partners, within 4 years, skilled delivery rates rose from 26% to 96%. And that increase has held for more than 15 years and counting. So today, it's my honor to be here to share how other members of the CGI community are leading the way to transform the landscape of healthcare. Please join me in welcoming the following commitment makers to the stage who are taking innovative approaches to improve the health and well-being of children around the world. Claire Green, from Care and Protection of Children Learning Network. Stephen Williams, from Chaniga Child Development Center. Donna Volpida, from the Mental Health Literacy Collaborative. Chris Thomas and Martha Thomas from the Defensive Line. To support the mental well-being of young survivors of the 2023 Turkey-Syria earthquakes, the Care and Protection of Children's Learning Network is partnering with Turkish organization Maya Vakfi to launch the Early Adolescent Skills for Emotions, or EASE program, for young Turkish and Syrian refugee earthquake survivors. Through this commitment, they will provide mental health and psychosocial support services for 64 young people and their caregivers in Turkey and evaluate the feasibility of implementing the EASE approach in earthquake-affected regions. In addition to improving adolescent health and well-being, the project will also strengthen the capacity of community partners to deliver services long-term. They will also explore scaling this low-cost, evidence-based, community-delivered mental health program to young people and their families in other disaster-affected regions. 1 billion of the 2.5 billion people worldwide who need mobility aids or other assistive devices can't access them. Chaniga Mobility is a social enterprise based in Uganda, dedicated to transforming access to assistive devices across East Africa using innovative bamboo technology. Since announcing their commitment, they've made significant strides to close that access gap for children. They recently moved into a newly established workshop that allows them to move from entirely handcrafted wheelchairs and other devices to small-scale mechanical batch production. As they've begun to exponentially scale product development and delivery, an estimated 650 family members and caregivers have had their physical and emotional burden reduced by their child's new independence with Chaniga's custom-made wheelchairs. Demand continues to grow, and so does their capacity to meet it. And Chaniga is well on their way to reach their goal of impacting more than 5,000 people with disabilities. As more young people in the United States and Canada experience mental health concerns, the Mental Health Literacy Collaborative committed to train more than 30,000 degree-seeking educators to support their future students' mental health. Since launching their commitment, they have built the online Mental Health Literacy Aware for Educators course to share with higher education institutions. The course includes a background on mental health literacy, why it's important, and how to advocate for their students. 15 university partners are piloting the program with students studying education, and the feedback is resoundingly positive, with the course receiving a 4.9 out of 5 rating. MHLC is quickly scaling the distribution of the program nationally and has launched an interstate working group with representation from 47 states. In response to the high rates of suicide among Black youth between the ages of 10 and 19, the Defensive Line committed to educate more than 40,000 youth-serving adults in Black and Brown communities in the United States. The curriculum uses storytelling to humanize mental health challenges and equips communities with the knowledge and resources to support the mental health and well-being of Black and Brown youth to prevent suicide. The Defensive Line is destigmatizing mental health challenges and shifting norms to encourage young people to seek care when they need it and give the adults in their lives the language and resources to provide support. Please join me in congratulating these commitment makers. And now, join me in welcoming our next group of commitment makers who are working on global women's health. Magda Desai from the Desai Foundation. John Varallo from the Global Surgery Foundation. Jolie Pont from Haitian Women's Collective, Nagina Muntayan from the United Nations Population Fund, last year, the Desai Foundation announced a commitment to expand its flagship Asani sanitary napkin program to thousands of villages in rural India, to distribute menstrual products and empower women as community leaders. They are back at CGI this year to report exciting progress on their work commitment to address period poverty and fight stigma around menstruation. The initiative has reached 479 villages, impacting more than 259,000 people and distributing more than 131,000 free sanitary pads. Desai Foundation has also created 954 opportunities for women to engage in production and distribution of pads through community-led sessions and digital engagement. They've been driving menstrual health awareness to improve health outcomes and build confidence for girls and women. In Kenya, 71% of facility-based maternal deaths are associated with cesarean section. The Global Surgery Foundation is committed to improve access to safe cesarean sections for more than 465,000 women and newborns across 4 counties in Kenya. GSF will take a comprehensive, women-centered, and integrated approach to implement a training and mentorship model through their award-winning online platform. Surgery teams, including individuals working in obstetrics, anesthesia, nursing, and midwifery across 20 high-volume health facilities, will complete the training, and facility readiness will be assessed to identify gaps, inform decision-making, and quality improvement activities, improving birth outcomes and validating further scale of this model. As Haiti continues to face political instability, the impact of the extreme weather and a growing humanitarian crisis, the Haitian Women's Collective announced a commitment in 2023 to provide Haitian women-led groups with critical financial and technical support to improve access to sexual and reproductive health services. Though challenges have prevented their sexual and reproductive health project from convening in person, Haitian Women's Collective continues to provide capacity-building support for local partners working on this critical topic through virtual conversations and webinars. Every minute, at least 2 women die from preventable health-related causes like pregnancy, childbirth, or reproductive cancers. To begin to reverse this trend, the United Nations Population Fund, UNFPA, is committing to launch Women's X Collective to mobilize $100 million in investment in women's health innovations across low and middle-income countries. Women X de-risks investments in women's health and provides an accessible entry point by offering investment-ready pipeline, resources, and scalable solutions, applying market intelligence to address market failures, and mobilizing blended finance. Women X will focus on improving health outcomes in 3 critical areas: maternal health, sexual and reproductive health, and reproductive cancers to impact more than 5.1 million people around the world. At this time of great uncertainty in our field of global health, my message to you and the other brave leaders launching your commitments today is remember the power of a long obedience in the same direction. Progress may not be linear or predictable. Sometimes momentum will be on your side, and sometimes it won't be. But with your patience and persistence and consistent action, I'm confident that you will make a positive difference in the communities you serve. Congratulations to you as commitment makers.
Please welcome to the stage Dr. Celine Grounder.
I'm Dr. Celine Gounder. I'm a physician. As you can see, I ran over from Bellevue Hospital in my scrubs to make it here to join all of you for a little bit. I'm also an epidemiologist and a medical journalist with CBS News, as well as the Kaiser Family Foundation. We're here at a pivotal moment. Global health is under enormous strain with pandemic aftershocks, climate change, and conflict, all while traditional funding streams like USAID, PEPFAR, and WHO contributions face uncertainty. Yet in this turbulence lies an opportunity to ask, what should the new architecture of global health look like? And what will it take to build something more resilient, equitable, and future-facing? We'll be exploring what a new global health architecture might look like, how to finance it, and how to ensure it is equitable and resilient. So joining me now is Dr. Barbosa, Director of the Pan American Health Organization. He has spent his career strengthening health systems across the Americas and advancing pandemic preparedness. So Dr. Barbosa, if we could just start with the big picture. We hear a lot about this, quote, new architecture of global health. What does that mean to you in more practical terms, putting aside the jargon, and what do we risk if we don't evolve our approaches?
No, thank you. I think that's a very important question at this moment with lots of uncertainties. And from my point of view, first we need to adapt. We are clearly facing a new era of the global health architecture. So first we need to adapt. We need to be more focused on the priorities that the countries are asking us to work on. We need to also to establish new partnerships and new alliances. I think that is very important that we really walk the talk about the multi-sectoral approach, talking with the private sector, development banks, and other agencies that can support this moment of transition.
So you mentioned development banks, private sector foundations. What have been some of those conversations more specifically that you've been having this week as to how they might step up to fill some of the gaps?
We are already implementing this in the Americas. Two examples. The Americas, unfortunately, we have the highest rate of suicide in the world. And the three countries with the highest suicide rate in the world are here, the US, Guyana, and Suriname. And the Americas was the only region in the world that the suicide rate increased more than 70% in the last 2 decades. So we are starting a very strong regional program on suicide prevention, training health community workers, physicians, nurses, non-specialized healthcare workers with a generous donation from a private company. We also established an alliance with the Inter-American Development Bank and the World Bank to strengthen primary health care. Not the traditional primary health care focused only on child and maternal health, but the primary health care that we need now, that can deliver health promotion, prevention, surveillance, that can provide better care for non-communicable diseases to reduce the unacceptable number of preventable and premature deaths related to non-communicable diseases with telehealth, telemedicine, connectivity, training for healthcare workers. This is very innovative because in the past, the loans from these banks were totally focused on hospitals and equipment. We need better hospitals and better equipment. But if primary health care cannot solve the problems, are not equipped to deliver the care with the quality that the people demand, the system will not be able to deal with the limited resources that they have.
You mentioned mental health and that this country itself has one of the biggest problems with mental health and suicide. Clearly, the healthcare approach that we do in the hospital is not what's going to solve that. What does a global health approach to mental health look like?
I think that the pandemic clearly told us how neglected mental health was in most of the national health plans. The pandemic called the attention, so in the case of the Americas, but I think that other regions that we are sharing this experience, we are working basically two pillars. One, to support the countries to change their legislation and their regulations. Because unfortunately, in several countries in Latin America and the Caribbean, they still had a legislation that put people living with a mental health condition like as they were prisoners. They were confined in hospitals, isolated, with no ties with the families, the communities, and the mental health care was provided only in specialized centers. So when you provide something only in a specialized center, this is a barrier because most of people, and the people that most that needed that kind of care, probably they will not have access. So we are also supporting the countries to change the model, to embed mental health at primary health care. So providing training, support to the primary health care facilities, putting together not only the health sector, but education, social development, in order first to reduce, to eliminate stigma and discrimination, and also to have a system that is able to detect the first signals and to act at that moment in order to prevent a person to, after years of suffering alone, with no kind of contact, or no kind of support, of help, will develop something more severe.
Now, in the green room, you also mentioned hypertension. Another condition we don't do a very good job of controlling here. Very often we'll see a patient in the hospital, in fact I have some on service right now, who have probably decades of complications or decades leading up to the complications we're seeing now with a heart attack or kidney failure. We don't do a very good job of controlling hypertension. What is it that you're encouraging countries to do on that front?
No, you are totally right. Unfortunately, the average in the world, because we had the launch of the global report 3 days ago, here the average is that only 20% of the people with hypertension have the hypertension controlled, only 20%. The average in the Americas is a little bit better, it's 25%. But in the countries that implemented an initiative that we call HEARTS in the Americas, because it's an adaptation of the global strategy, we have the proportion of controlled hypertension goes to 62%. And we already have in this region 18 countries that have implemented this initiative in more than 80% of the network of primary health care centers that they have. So this is really a new way. It's a comprehensive package with training, protocols, access to medicines, but also indicators that can track the progress of the implementation. Because Unfortunately, sometimes the first way, the first moment that a person realizes that they have hypertension is when they have a stroke or a heart attack. So I think that this contributes a lot for the almost 38% of preventable deaths that we have in this region related to non-communicable diseases. And embedding this response also at the primary health care, I think that's the only way to change the game. But of course, if we are talking about the people that don't have time to go to the health center, it is also very important to build a strong alliance with private sector, so at the workplace they can also have the opportunity to measure their hypertension, their glucose levels. So think not about a disease, but thinking about a more personal and community-centered approach.
So a more decentralized approach to primary care. Do you have examples you can share with us of private sectors, business places taking on that very approach that you're describing?
Yes, we have some countries in the region that this partnership is really important because this is allowing the health sector to go to schools, to have teenagers being vaccinated against HPV, because if you don't deliver the vaccine for HPV at schools, the coverage will be low. Health sector going to construction sites, because there you have a lot of young men that sometimes have TB and they're not diagnosed properly, or you have adults that have hypertension are not diagnosed. So I think that is not only think about the primary health care confined in the walls of the health center, but the really main strength of primary health care is that it is closer to the community. So using the network of hundreds of thousands of community health workers that we have in this region, we can reach the workplace, the slums, where people sometimes don't have time because they work in informal economy. So if they don't work one day, that day they don't have an income. So really we need to go beyond the health center and to have a more closer collaboration with the communities.
My friend, Dr. Atul Gawande, you may be familiar with his writings in The New Yorker, did a really wonderful piece about community health workers in Costa Rica and the impacts they've been able to have on health. It's a much cheaper system than what we have here, and they have much better outcomes. Are community health workers part of your approach, and what are some examples of that?
Yes, they are part. We are encouraging the countries to work with them, to have them as an essential part of this renewed and strengthened primary health care. The way that we work in the region is not to replace the national health authorities. We work to strengthen their capacity. So just to give you an example, we have a virtual campus for public health that now is offering more than 150 different trainings. Last year, unfortunately, we had a record number cases of dengue fever, more than 12 million cases of dengue fever in the region, around 8,000 deaths. And we know that if the services are well prepared, the nurses, physicians, and the health community workers are trained to identify the first signs and symptoms, we can probably almost 100% of the deaths will be prevented. So the problem is that with the rotation that we have for the workforce at the primary health care, the nurses, physicians that are working now, they were not there 5 or 6 years ago when there was the last outbreak. So with this training, we had more than 450,000 healthcare workers, because we have different levels of training that engaged, and when we had the countries taking this training and organizing better the services, including the health community workers, the mortality immediately declined to almost zero.
Now, many of the problems you're describing, well, in the United States, as one example, your zip code is your #1 predictor of your health. And that's really a summary of a number of other factors: your race, your ethnicity, your gender, your community wealth, your environmental exposures, and the list goes on. How are you addressing some of those social determinants of health? Because it's not just ministries of health that need to be involved and at the table, it's other partners as well.
Indeed, first I fully agree with you that the place that you live probably is the best synthesis about your life conditions, your quality of life, the access that you have to health services and other social services. So primary health care with the health community workers closer to the communities, they can work the difference that sometimes in the big cities in Latin America, in Mexico City, in Bogota, in São Paulo, in Buenos Aires, you can have a slum, and 500 meters, you can have a high-end condominium. So this idea to have exactly not only the average of a certain condition, for instance, immunization coverage. The average in a city like Bogota with, I don't know, 80 million inhabitants, tell us nothing. So we are working with the countries to have this kind of micro-planning in the big cities so we can really identify where are the unvaccinated, where are the people that are missing the follow-up for hypertension or for diabetes in order to identify the ones that are at the highest risk and to bring the care closer to them.
Now, going back to this concept of new architecture or framework for global health, I've heard a lot of people say that there's a lot of opportunity in this moment and trying to find reasons for hope or a silver lining. Why wasn't this redesign already underway before cuts to U.S. funding exposed vulnerabilities with USAID, PEPFAR, funding for the WHO? Was complacency part of the problem, or were the incentives misaligned?
I think that you have a combination because, unfortunately, now we have for WHO, because for PAHO, the Pan American Organization, the US is still a member of our organization, but of course, we have a lot of uncertainty about their financial contribution. We don't have an outcome of the assessment that they are performing on the international organization, but for WHO and other institutions, you have at the same time the funds from the US and the several countries in Europe, they are reducing their budget for international and humanitarian aid because they need to increase their budget for defense. So it's I think that a combination that, of course, is not very good, but it's important to adapt because I don't know, maybe I am a little bit pessimistic. I don't think that this will change in 1 or 2 or 3 years. So it's important really to adapt. For some countries, I can only imagine the problems that you have in some African countries, because I'll give you one example from our region. In Haiti, now we have 16,000 less people receiving antiretroviral treatment than we had 1 year ago, due to the termination of some projects that they received some funds, but also due to the increase of violence, because some people, they don't feel comfortable to go to a health center, or because the health center is closed. We have in Haiti only around 35% of the health services are functioning. So we are really facing a situation that's very complex. For this reason that I mentioned at the beginning, that we need to adapt, so to value what is the most indispensable functions and our mission, our core activities, what will benefit most the countries at this moment. I think that this process to prioritize and to change the way that we think prioritizing is strengthening their national capacity, and at the same time, building new partnerships and looking for new partners to support us.
Financing is always the big elephant in the room. People can't be counted on to do this kind of work just on the, out of their goodwill and volunteerism. You really do need professionals doing this work. How do we secure sustainable, predictable funding when these political winds shift?
This is a challenge both at the global level, but also at the national level. We recommend that the country should have as public expenditure for around 6% of their GDP. Now, this is considered this is the minimal public expenditure to guarantee universal access. The average in Latin America and the Caribbean is around the 4.3%. We have 6 countries that are above the threshold of 6%, but we have the average is only 4.6. So we really needed to give elements to the Ministry of Health to improve the dialogue. Because the Ministry of Health are all the time saying, I need more money. Ministry of Finance are saying, you have money, you need to improve your managerial skills, the performance, the efficiency. And sometimes I think that both have a certain part of the reason in what they say. So in this moment that you have a very limited fiscal space, it's important that the Ministry of Health needs to present very effective projects. So when we are talking again about reducing the preventable deaths related to non-communicable diseases, we are not talking only about the health outcomes. We are talking about the huge economic losses that the countries have when a person has a stroke, that will need 10, 20, 30 years of support when a person has a heart attack. So we need to present proposals to perform what I call advocacy with evidence. So to show clear that for each dollar that will be invested, we will have a return in order to have a more effective health system that will deliver better and will produce a real change in the way that the health agenda is in the country.
Dr. Barbosa, in the 2 minutes we have left, do you have any final thoughts that you want to leave the audience with?
Now, my final thoughts maybe is about the hope. I think that we are really in a very challenging times, but when we see in this General Assembly, the commitment, the countries discussing how they recommit with non-communicable disease, and at the same time to have a new audience, prime ministers, presidents, ministers of foreign affairs, stakeholders, private foundations, private companies. I think that is also a moment that everybody thinks that we need to be closer and to clearly think about the projects that will change the life of people, that will increase access, that will reduce the unacceptable inequities that we still have in the world and with the countries.
Well, if you would join me in thanking Dr. Barbosa. Next, we have a panel that will be helping us grapple with some urgent questions. I think you're going to bring up the chairs. Okay. Do you want me to move here? So next panel to help us grapple with some urgent questions, how we rethink the architecture of global health, how do we finance and govern systems that are more equitable, more resilient, and more prepared for the crises ahead, and most importantly, how do we ensure that the communities most affected have a true voice in shaping the solutions? So first, I'd like to introduce Dr. Brendan Carr, who is the CEO of Mount Sinai in New York. He is both a clinician as well as a public health leader, focused on bridging the divide between healthcare delivery and prevention. And this is not the Brendan Carr who fired Jimmy Kimmel earlier this week.
Appreciate that very much.
Dr. Tabinda Sarosh, who is the CEO of Pathfinder International, is an expert on the intersection of health, gender, and climate, working to ensure women's voices and experiences drive resilience strategies. And finally, Mr. John Arne Rodingen, who is the CEO of the Wellcome Trust, who offers a critical funder perspective, particularly in this moment, with a career devoted to building and sustaining global health financing and partnerships. Join me in welcoming our panelists. Starting with you, Dr. Carr, you've argued that healthcare and public health too often run on parallel tracks. Where do you see the greatest opportunities to braid those more tightly together?
That's a great one. The fact that they've run in parallel and haven't intersected and communicated and in fact have had turf wars is very much an American problem, which is something that ideally we don't export to the rest of the world. In many places, the Ministry of Health has a shared responsibility, as this room certainly knows, for what's happening in the public health space and what's happening in the healthcare space. And I guess I would say that the opportunity there is for us to learn from our international partners as we engage with them and try to figure out a way to really thread the needle on both. I'll give just, we have two key partnerships, and it's okay to talk about these a little bit. We have several, but two of the big ones for us. One is in Guyana, one is in Nepal. They're structured differently. I'm happy to, to take a little bit of time later to unpack them if it's helpful. But what we realize is that when we engage with folks that deeply understand what's happening inside of those countries, they articulate for us the connectedness that somehow in the U.S. gets lost, which is to say, building a public health infrastructure that bridges into primary care and preventative care and accounts for, I heard you talk about zip code as a great predictor of your health outcomes. That's critically important, but so is the downstream. And making sure that there's capacity on the downstream to take care of referral disease really paints the entire picture of health and public health in a way that we would all want it to be. And so we try really hard to learn and to be humble about not creating the same boundaries between the two that exist too often in our world.
So this question is for all of you, but perhaps starting with Dr. Sarosh. Building hospitals abroad is often framed as progress, but how do we avoid white elephant projects and instead create adaptable, sustainable systems of care?
Thank you so much. Firstly, very grateful to be here. And for those of you who don't know Pathfinder, we are a women's health organization. We've been here since 1957 and worked in 120 countries across the world. And this question that you ask is very pertinent for me because we've been programming on the nexus of health and climate for some time now. I've traveled here from Pakistan, right, leaving behind a country which is facing lots of floods. And 2 years ago, when the floods happened, 625,000 women were pregnant and displaced into the campsites, and 65,000 pregnancies were taking place every month in the campsite. So when you talk about adaptation and readiness, this is what is going to become a regular feature if we do not invest into health systems that serve women and children right now. And I'll give you another example from our work in Bangladesh, and where, cyclones hit us regularly every year, and yet in the shelter homes, women do not find simple things like menstrual hygiene products. Girls who are sometimes left in the shelter homes for days when cyclones happen do not have access to menstrual hygiene equipment. And for them, that is a very catastrophic situation. And when we talk about building climate resilience, that's what we mean. We mean building resilience of the communities, of the women and girls themselves, but most importantly, the systems. Why have not our systems been developed to absorb this? One, because we are overburdened. The countries that we work in are low and middle income countries, and we need better and more innovative financing and governance schemes, I guess, to carry that forward.
Mr. Oringen and then Dr. Carr, same question. So this idea of building hospitals It's something I often see wealthy donors want to do and have it named after themselves. But how do we avoid a white elephant and instead create adaptable, sustainable systems?
Yes, I was very pleased to hear Dr. Barbosa talked about health as an investment. So it means an investment in people, it means an investment in human capital, it's an investment in society because we create jobs in the healthcare sector. It's almost 20% of the economy in the United States, it's 10% of the economy in OECD countries, maybe not more than 3 to 5% of the economy in developing countries, but still, it's a substantial part of the economy. And then we also have health industry. And I think what we're seeing now is a call for looking more at health as an investment. But it's also a human right. And I think that's also a starting point. And why do I say that? Because who are responsible for human rights? It's individual countries. We heard a lot this week about sovereignty. It can be framed in the negative way, because in a way it can be framed as we are in it for ourselves only, or it can be framed as we take responsibility for our citizens and our people. What we have seen coming out of the pandemic is really more and more leaders from the global south, from Africa, from Asia, from Latin America, taking responsibilities for the health of the populations. But that responsibility needs to start with the basics. It needs to start with community health. It needs to start with primary health care. And that's why I really agree on the fact that healthcare systems and public health needs to be seen in conjunctions. If you have very limited resources, you need to start with the most cost-effective interventions. The most cost-effective intervention in health and public health is vaccines, just as a starting point. And then we have cost-effective interventions to really make sure that children survive, mothers do survive pregnancy and birth, and then we need to build on from there. So I would not say hospitals is the first investment. They are necessary, but they need to come after we have done the basics right.
Dr. Carr.
I'm just grateful that it's not the healthcare guy that talked about healthcare, business, and finance first. That makes me feel good. Because it is a reality, and of course, the hospital is the galvanizing principle for many. It is the shiny object, the hope giver that that we can rally around. But it is also, increasingly not the way that care is delivered anywhere in the world. When we're watching this transformation happen in the United States, for sure, where there is a massive pivot from inpatient care to outpatient care. There's a lot of reasons behind that. There's a lot of feelings around that. They're all worth discussing and exploring. But again, one more time, when we think about what we probably don't want to export to the world, it's this idea that the only hope is this new massive building where we do complex care. I think, and I'll just sort of circle back to places where there's opportunities, and the donor naming is an interesting issue. Our partnership in Guyana is born from the fact that oil was found off the coast of Guyana. And it created the opportunity for the country to really redefine itself and to build a first-rate public health infrastructure and a healthcare infrastructure. It led to conversations, and also, by the way, education and infrastructure. But it led to conversations around what an electronic medical record would look like for the country. How you build a workforce to deliver care, and you can imagine sort of, and on and on and on. And yes, at the end of the list of the many things that need to happen, there is the need for coronary care for complex disease that would happen in a hospital. But the answer, I think, to your question is that it really requires us to bravely say the problem is really, really big, and most of the solutions, as you're both pointing out, are not in that, the big hospital, the object that we cling to because we see hope when we see a big shiny new building.
Dr. Sarosh, women are often on the front lines of both climate change and health. It's central to your work. How can we design financing and partnerships that are both gender sensitive as well as climate smart?
Yeah, thank you for that. Something that I keep repeating to everybody is that when we are given an opportunity to re-architect this, I think this time we should focus on outcomes that are low cost and high touch, because we are, grappling with resources that are shifting. So let's invest in things that women and girls actually feel. And what does that translate as? That translates as continuity of services. That translates as medicines on the shelf and food at home. So that's important. Secondly, women's leadership. So 70% of the workforce of health systems and social care systems across the world is women. But yet we do not see women at the leadership positions where it actually matters, where the financial decisions are made on how much funds are going to be allocated and how much research and design interventions, how many of them will focus on women's care and needs. So that's another point. Third point that I always make is innovation. Do not underestimate low-cost innovations. Yes, there is a risk with innovation, and many people are hesitant to scale them. But I often give the example of Tanzania, where the government just scaled up a project called M-Mama. M-Mama was simply a project that was connecting women in obstetrical emergency situations to transporters, public transport system and private transporters, so that they could be transported to the health services in time, because that is the delay that was a big cause of maternal mortality. And then what did we see in the DHS? We actually saw the maternal mortality rate go down. So do not underestimate the power of low-cost, high-touch innovations.
Mr. Rotingen, from the funder perspective, what makes an initiative scalable and fundable? What are some of the lessons from past global funding efforts that should guide us now?
Yeah, so I should clarify very upfront that Wellcome is a funder, but we are a funder supporting science to improve health everywhere. But to improve health, we are so dependent on the system being able to scale up these innovations, scale up these new technologies. And we have been very successful in doing that in the past, and we should be successful in doing that moving forward. It is about really addressing the big public health needs. I think in many ways, the biggest transition in global health came as a consequence of new innovations for treating AIDS patients, so antiretroviral therapy. And then the large outcry of the inequity in access to those medicines, that's completely changed the picture. It changed the public-private and philanthropic partnership. We managed to have a system of generic production, of tiered pricing, and making sure that we could deliver at low cost interventions at scale where the needs are the highest. And I think that's what we need to continue doing. But we need to do that based on country decision makers' priorities. We cannot set the priorities in London, where I sit, or here in New York, or in DC, or in Geneva. We need to allow country decision makers to make their own priorities. To do that, they need an evidence base. They need to understand what are the most effective and cost-effective interventions, what can they afford, and let them plan and steward their health system, both with public and private provision of services. And then aid and external support can be on the margin, supporting that and extending and training and collaborating and partnering and be catalytic, scaling up opportunities. Wellcome is currently investing in a large clinical trial on TB vaccines together with the Gates Foundation. If it's successful, and we hope at least it's sufficiently strong in effectiveness, it will be the first vaccine on the market in 100 years for tuberculosis. Tuberculosis is still the biggest infectious disease killer in the world. And it's really affecting people in poverty, and there are structural reasons for this. But we need to scale up these interventions, and actually to do that, to make sure that we can shape the markets, really produce at scale, produce in developing countries, we need a system that is also coming together on the global collective problems. So it's a balance of giving more responsibilities to countries, and actually that's what we see now, and domestic resource mobilization, political leaders in Africa taking responsibility, but we shouldn't leave them alone to do that. We need to continue our efforts in supporting, but in different ways. We need the money in the system. I'm really concerned about the reductions in development aid for health, but we also need to really understand that we cannot continue delivering that by vertical individual programs, by high-cost implementers coming from the north. We need to really rely on local systems, but we need to shape markets, and we need to provide innovations to them.
With Dr. Barbosa, we were talking a little bit about this new framework for global public health. What should that look like in each of your opinions, and how should we reform the way we approach global public health? This time I'll begin with Dr. Carr.
I mean, I guess I would say two thoughts on the front end here is that as uncomfortable as it is, you know, when both of you are talking about hard choices being made about what can't be done, and that gets discussed all the time in global health. I don't think it gets discussed broadly enough in the U.S., or certainly when the U.S. is talking to outside of, you know, the global health communities that perhaps we run in the general public discourse. Those are hard conversations. Those are conversations that are now starting to happen in the U.S. too, as we have not pulled just back on funding for global health, but we pulled back domestically for funding of folks that do not have private insurance. There is coming, I think, a mechanism, a time where we're going to start to think about how we pick and choose more carefully than we have historically about what our expectations are and what we're setting. And while that's been a conversation in the global community, it's not been a conversation in the U.S., and we are again going to lean on the global community to help us to think about whether or not and how to make those hard decisions. I guess the second piece that I've been sitting here thinking about is the peer-to-peer partnerships that happen outside of the U.S. So, you know, our programs very often are an academic medical center hub, a university internationally, you know, with a partner hospital, and then a governmental agency. Sort of how they're usually set up, so that anything we're doing in partnership with the university, often a school of medicine and a hospital, can then be, magnified or amplified and grown into other systems because of the interventions that happen on the policy side, because of the governmental involvement. And one of the things we're hearing more and more is it's really hard to work with us. It's easier for us to see ourselves growing to be something that's 10 years ahead of us rather than 50 or 100 years ahead of us. And so can you create for us a relationship with a near-peer partner globally? And so there are amazing interactions that are happening between our partners in Nepal and our partners in Kenya, where they're, one is extraordinary in one portfolio, the other in the other portfolio, and there's now this wonderful bilateral exchange, including swapping of clinical fellows to learn gynonc surgery, or to learn minimally invasive surgery, or to understand the doula program that was born in Nepal, or the way that they're using rural outposts to really bridge a network of, or a system of care together to get people primary care, emergency or urgent care, and then referral care when they need it. So two disconnected thoughts, but both of them very much on my mind as we're going to face really hard conversations in this country and broadly moving forward.
Dr. Sarosh?
Yeah, thank you. I like it when you say about what you say about setting expectations. I think in a low resource setting that we are seeing in the global health, our expectation is that as we go around doing global health work, this time, let's not silo ourselves. Let's develop integrated service delivery packages and have multi-sectoral connections, because women's and girls' lives, they're not happening in silos. And most importantly, when you talk about localization, one thing that needs to be emphasized is who's going to be at the table. That usually ends up the health ministries. I think the finance ministries and the planning and development departments need to be on the table, and that's my expectation from everybody in the countries that I work with, that they come to the table and solve this in a very multi-sectoral way, so that we have very long-lasting integrated service delivery packages which are low on cost and high on sustainability. Thank you.
And I'll give Mr. Rotingen the last word here.
So global public health needs to be about health outcomes. And we've seen tremendous progress over the last, let's say, 25 odd years. We've almost increased life expectancy in sub-Saharan Africa 1 year every year. We have halved child mortality. We've been able to really reduce the incidence of the big infectious diseases. And reducing incidence means that, yes, fewer people are sick, but it also means that the risk for everyone is lower. That's the nature of infectious disease. And we've done that at fairly low cost if we compare to the cost of health systems in my home country, and this country, and other countries. So I think we just need to continue to provide that basic scientific understanding. What are the most effective interventions when it comes to the population at large? We should be able to do that. Population health is about the health of the full population. we have really positive deviance when it comes to looking at countries. Some countries are delivering really good health outcomes at a GDP per capita that is fairly low, and at an expenditure per capita that is much, much lower than high-income countries with similar health outcomes. So we need to learn from those systems that are delivering good health outcomes for less, because we have limited resources in aid, and we need then to at least maximize the national and domestic resources to deliver good outcomes.
Well, thank you, Mr. Oettingen, Dr. Carr, Dr. Sarosh, for your comments today. We will be closing this panel, but moving on to the next shortly.